Oh, hey, Chris.
Hey Chuck, how are you?
Great. How are you?
Cold. It's frigid here, man. It's so
It
cold.
it is really cold. Crazy cold. I've already been out, had a fun meeting, which we can talk about. But in the interest of
You went out? It's
I,
in Celsius minus 13 degrees here in St. Louis, which and those of you in America, it's 9 degrees. It is cold.
it's cold. That's without wind chill. It's cold. I did. We'll talk about that. But why don't we give an overview of what we're going to do? Because we like to try to do that.
Yeah, so we're gonna share a listener tip with regards to our ongoing trigger finger conversation, which I think is super interesting that we're able to talk about it for that long. And then talk about elbow arthroscopy, which was also a listener request, sort of the basics and how to start, and maybe what are the current uses you have for your practice, and how you think it's going to evolve over time.
Yeah, obviously I love that topic, and I think we can make this so it'll be interesting and helpful for many, hopefully all. But we'll make it technical, and I think it could be helpful.
So did you? We had our first round of orthopedic surgery residency interviews yesterday. Did you happen to catch the one podcaster in the application group?
I did. I didn't have a chance. I'm in the room where there are very short interviews, so as much as I would have liked to talk more about it, I saw it but didn't pursue it. But I'm hoping you're gonna enlighten me.
So I guess a 20-minute interview feels long after some of our shorter fellowship interviews. So I was, and it was a very pleasant conversation. And actually, this was one of the interviews that could have gone on for a lot longer because I really like this applicant, and I think so did my co-interviewer, Dr. Ryan Nunley of podcast fame and neurosurgeon. But in the middle of it, I was like, "Hey, what's it like to be a podcaster?" And then we had a little conversation about it, and then Nunley looks over and he's like, "So, do you know any famous podcasters?" and starts pointing at me, and he's like, "No, really?" I'm like, "Oh yeah, we have a podcast." And Nunley looks over, he's like, "Yeah, it's called The Uppercut, right?"
Well,
So then the applicant actually is like, "Oh yeah, I actually think I listened to you guys like something about like how to do well at interviews." And I'm like, "Okay, fine. You probably didn't actually listen to us. Like I've been on some other podcasts, maybe you know from that." But he's like, "No, no, no. It was two of you guys, and you're both hand surgeons." Oh, no, yeah, you were at WashU. I was like, "Yeah, the other guy was Goldfarb in the other room that you interviewed with." He's like, "Yeah, like I really liked that episode. Thank you so much." He's like, "Yeah, yeah, yeah." So a little bit of a backpedal. I do think it was sincere. Very, very nice guy and an excellent applicant. But it was just a funny little anecdote. I didn't ask to see his receipts in terms of recently listened episodes, but apparently there's not much out there. If you type in like orthopedic residency interviews, I think we come up. I haven't verified that yet.
Oh, interesting. Yes, it is very different vibe with our residency interviews versus our fellowship interviews because I think there's whether it's forced or not forced, there's a lot more discussion, not forced by us, a lot more discussion about the pod during fellowship interviews.
Yeah, then clearly it sometimes it comes up, sometimes it doesn't, but it's fun nonetheless. So anyway, let's go through the listener tip that was shared by one of our listeners. So we've had that conversation in the past about when trigger fingers don't go perfectly well or smoothly. And we've got a listener email from Chris Gayton. So thank you for sharing that, Chris. And two things that may help out in the difficult trigger finger patient. At 6 weeks, I will consider a steroid dose pack with therapy. Also, I tell the patient that at 3 months, I'd recommend an injection. Fortunately, I don't have to do many at the 3 month mark, but those that do have seemed to get better. So, what do you think about that, Chuck?
I think I'm embarrassed because we didn't we didn't mention this when we had the discussion. So I am not a huge fan of oral steroids, even a dose pack, but I think it is a perfectly reasonable thing to do at that 4 to 6 week mark. I also share the 3 month mark is when I consider an injection. And I'll be honest, I had a patient recently call in after a trigger finger release on each side, and it was wide awake, and the patient was moving perfectly in the OR. And there was no evidence of any mechanical problems. And he called in 10 days after surgery, and his finger was stuck in flexion. And I'm like, what? Like, how does this happen? And but that's neither here nor there. I love this tip, and I think I am grateful that he wrote in.
Yeah, absolutely. I actually have used, and I replied, I was like, I actually totally forgot that I use steroid injections. And again, like him, it doesn't come up very often. I actually have a little bit of a lower threshold to use both oral and steroid injections. I think that even now, there's some literature in the arthroplasty, hip and knee, that using steroids very early on, including right after surgery, is safe and can help. So I'm not as shy anymore about using a steroid dose pack as early as 2 weeks post-op. I haven't again thought about it terribly much, just because it fortunately doesn't come up that much, and I will do an injection even at 6 weeks.
I love it. I think all true, all fair. I think the risk is incredibly low. And again, this is not a common scenario. I want to tell you about why I went out in the cold this morning.
Ah, yes, please do.
So there are a small group of us who are interested in artificial intelligence and LLMs and how we can better incorporate and use them in our clinical practices and in our practice, so to speak. And it's been really fun to talk about, and we based our discussion around on a Harvard Business Review article, which sort of talks about how to implement AI now, and it's a general article, but we personalize it to medicine, and it's really fun to have people who are engaged and geeking out on this, so to speak, and it's fun to talk about, and there are clear opportunities. It's just another one of the examples of who can find the time to take the steps to do this, even though it's going to save a lot of time and money down the road, clearly in some domains.
How big is this club?
Oh, it's very exclusive. It's very, very exclusive. So it is, I don't think they'll mind my saying. So Jason Strelzo,
Uh-huh.
who is, I'll say he's the most AI intelligent person in the group. Really smart overall and has just a lot of great insights. His wife, who we can say that now, Kelly Hines, foot and ankle surgeon extraordinaire, who is she's really about data. She has AI experience and knowledge, but she is just really into data and really smart in those domains. Puya Hosanzada, who is a jack of all trades, I would say, and just interested in talking and learning more about this. And he's the one who created the AI survey, which went out, and we're considering how to provide some education for the department. And Larry Cross, who works in our data team. We have a small data team in our department, and Larry's awesome. And Larry joined us this morning. So it was five of us this morning.
Very cool. It's a intimate group. Is it kind of like for our Stranger Thing fans, like the Hellfire Club, so to say?
I'm not a Stranger Things guy, so I can't answer.
All right, I'll leave that one there for anybody else. That's really cool. Hopefully, things will evolve. Interestingly enough, there's just a rush of papers about AI in the literature, just of various uses, whether it's to stratify risk. We had our dabbling with coding, and I was talking about coding with our current fellow Pradeep, who's on service with me, and he's like, "Yeah, but like, do you ever think AI is going to be used for coding?" I was like, "Well, let me tell you, there's a paper that's in press right now that hopefully will shed some light." But yes, it's going to be very interesting to see where all of this goes.
Not to go down a political minefield, but one of the challenges with AI and coding is the AMA's ownership of codes, the CPT process, which I just can't believe that's intellectual property still, but it is. And I don't know, that's a real stumbling block, which is interesting and actually AMA is being attacked about it now.
Is it was that the 70s or 80s that started?
I think that's based on work out of Harvard in the late 80s, is my recollection.
Because I would think, like, if the original Steamboat Willie Mickey Mouse copyright is up, at some point this CPT copyright's got to be up, right?
Yeah, well, Disney just signed a licensing deal with OpenAI, which means their characters can be used to create. So I don't even know how any of this stuff
Oh,
works. Maybe we
this
need an
is
attorney.
exactly. So that's really cool. I'm glad that there are good people fighting the fight for AI. Speaking of Dr. Hines, it was so much fun to walk into the indications conference yesterday during a break from interviews and just talk about, hear her talk about syndesmotic injuries and ankle fractures and Liz Franks, and made me feel like, an orthopedic nerd again. It was really fun to hear different perspectives. She's an awesome educator.
Oh, it is. There's nothing like, you have to be, at least I'll speak for myself. I have to be in the right frame of mind, but when I'm there, it's just great to learn. I mean, we've said that over and over, and that's one of the reasons I got my MBA and was so happy with it. But learning from our peers is amazing.
So before we dive into elbow arthroscopy, we should thank our first sponsor. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job does not have to be. Join Practice Link for free today at www.practicelink.com/the upper hand.
So I was recording an intro for an upcoming bonus episode that we're gonna have, and I couldn't. I was typing out what I needed to say because I, as much as I like to think I can do things perfectly off the cuff, I was like, it's just gonna make it easier. So I was writing it out, and I couldn't find a practice link copy. So I just kind of typed it out from memory, and I think I nailed it, except for the practicelink.com at the beginning. But we'll
Uh,
see if any listeners can tell me the difference between what we just said and what I say in the next episode. I don't know. You'll get a pat on the back or a bonus, a gold star of some sort.
yes, that'll require a close listen. Only a few select listeners will go that deep, I'm certain.
So the request was about elbow arthroscopy. So I guess talking about for those of us that are not familiar with it, first we can ask you about what your current indications are for elbow arthroscopy, and then what procedure you think would be a good place for somebody to start with, whether they're in fellowship or whether they're out in practice. And then we can get into the technical details about things like positioning, portal placement, risks of the portal placement, and then technically how you move around in the elbow.
Yeah, that sounds great. That sounds great. I will say that elbow arthroscopy is, at least in my world, it's done by, or our world, it's done by three different groups, which is always a problem. The shoulder and elbow surgeons like to do some elbow arthroscopy. The sports surgeons like to do some elbow arthroscopy, and the hand surgeons. And like distal biceps repairs, when that many people are dabbling, then no one does a huge volume. I've been fortunate that one part of my practice, the adolescent practice, has provided just a huge volume, which is great and has made me more facile. And thinking back of where I've come from, it's been amazing, and I feel extraordinarily comfortable with the process. And I remember I used to stress out about risk and all that kind of stuff, but I don't really anymore. But I do think I take a lot of precautions.
So, what are your current indications? When do you think elbow arthroscopy provides a big advantage?
Um, so simplistically, the pain level after surgery with a straightforward elbow scope is almost none. And it's remarkable that we have adolescents come back, and I call in 8 or 10 pain pills, and routinely families say we took one pill, and that's because I tell them to take it, after surgery before bed in case the block wears off in the middle of the night. So that's the indication, right? Post-operative pain is dramatically less through these, portals. And there can be 4 or 6 portals, but my main indication is osteochondritis dissecans or OCDs of the elbow. That's probably 70% of the scope volume, maybe 80% of the scope volume. I'll do early arthritis as well, and I'll do contracture releases. And those are different, each of those, probably escalating level of technical expertise required, but all eminently doable. And when I do an elbow release, and we can get into it a little bit, we don't want to go into the weeds there, but I always tell families if it's safer, then I'll make a small incision. And so there's no fail there if you have to make a small incision. I think that's a good way to think about any procedure where you're making a small incision, be it arthroscopic or open. It's not a fail to extend your incision or make an incision if need be.
All very well said, and I'm interested to learn a little bit more. So, for the contracture releases, are these better off arthroscopically for those that with difficulty getting terminal flexion, meaning just simplistically something tight in the back of the elbow versus gaining terminal extension, and analogously something tight in the front of the elbow?
Yeah, for most of my successes, these are patients who are immobilized too long after a dislocation or something like that. They're typically immobilized in flexion, and the challenge is gaining extension. And so it also, that's where the neurovascular structures are closest. And so an anterior capsulotomy, it's not really a capsulectomy when you're doing it arthroscopically, is the treatment of choice and can be, very successful. And because it's minimally invasive, you don't get the swelling post-op, and patients just progress more quickly. Posterior releases, and we're just talking soft tissue, posterior releases are a little trickier if you're trying to gain flexion, because just doing a posterior capsular release may not be enough, and releasing the posterior MCL may be required. And for me, that's an open incision. You have to deal with this pesky nerve, the ulnar nerve. And so for me, it's most simplistic if I'm doing a anterior capsulotomy.
And for those that are on the junior side, I mean that is the floor of the cubital tunnel, so you can see you're real close there, which obviously can make somebody, no pun intended, nervous.
Ah, I like that. Yeah, so being again, just circling back to release the posterior MCL and leaving the anterior MCL alone, obviously for stability point purposes, you have to move the nerve out of the way. That doesn't necessarily mean you have to transpose it, although a lot of times when you're lacking elbow flexion, you do transpose it because A, you're releasing the posterior MCL, and B, the nerve has not been that tensioned in a while, and so just transposing it makes some sense.
And you're going to work aggressively to flex that elbow. So those reps of repetitively flexing the elbow. If you don't transpose it, you're just making that nerve just continuously angry, I would imagine.
Yes. So maybe we can circle back to some technical pros on this one, being that it's the most challenging of the procedures, I guess I would say, and the most risky.
So in past episodes, at least one perhaps, and then I remember in training you would say that tennis elbow or lateral epicondylitis is a nice way to get started on the elbow arthroscopy. Do you still feel that way? And then what are your, do you still use arthroscopy for lateral epicondylitis? I noticed you didn't mention it in the conditions for your current indications.
Yeah, well, first of all, for me getting started, it was a great indication. And I think I know we have talked about this frequently in the past. When you're starting your practice, you want to give, obviously great patient care, guaranteed great outcomes, and you have time. Um, Nowadays you and I struggle to, and it's a great problem to have. How do we efficiently, effectively, safely take care of all our patients without wasting time? And to me, it can become, at least in my hands, elbow arthroscopic treatment of lateral epicondylitis is a very reasonable modality, but it takes a lot more time, both for me and for the nurses, for the setup, and all that kind of stuff. And so it doesn't make sense in my practice day. Plus, I don't do that much lateral epicondylitis. But as a starting point, it was just one clear indication for arthroscopy that gave me the reps that allows me to be comfortable today, even though I really almost never do it today.
Yeah, I was going to ask you whether it's just a general change in surgical indications, or I guess it seems like a long run for a short slide, given you know, uh, if you're doing surgery for lateral epicondylitis, it is not a technically demanding surgery from an open approach.
It's not technically demanding. It's a small incision, anyways. So yeah, it doesn't make sense today. So therefore, for others, it might not be a great training and experience gaining tool. For me, in the past, it was. Yeah. So I think you have to find other ways to get comfortable, most likely, and that's usually the lab with an industry partner or at a meeting. Is another great option.
So the OCDs are there, in and of themselves, a different episode, I think. But you also mentioned early arthritis. So, in general, how do you indicate those patients, and what do you think you can tackle with, a simple quote cleanup? I wouldn't say simple, excuse me, a straightforward cleanup.
Yeah, I think elbow arthroscopic debridement for early arthritis is a very good indication. And typically, you're doing a couple of things. Your main goal is to help with motion. And so that's usually both in the flexion and extension domain. And so you are releasing the anterior capsule. You are removing the coronoid tip arthritis, which will make it more prominent. And if you're thinking about the coronoid tip when you're flexing the elbow, assuming you don't have a posterior capsular problem, when you're flexing the elbow, a prominent coronoid tip prevents maximum elbow flexion. So you can take that off arthroscopically safely and hopefully efficiently, and then flip it around posteriorly, capsular release, which helps you regain flexion, and olecranon tip removal, which helps you gain extension. And both of those bony procedures can be done with a small osteotome or with a burr, and very straightforward. Those are the baseline things. So scope, debridement of synovitis, which is inevitably present. Sometimes you have to create a little bit of a working space, which can be technically not straightforward, and then you get down to business, which is the bony work and the soft tissue work. If you are advanced and this is more significant arthritis, then you can take it to a whole nother level, at least in my mind, which is recreating the recesses anteriorly and posterior to accommodate the coronoid, and the olecranon because those recesses disappear in elbow arthritis. You can see that on x-rays, but recreating those, that's a whole nother level in my mind. Doable for sure, but not straightforward.
Is that surgery that typically you feel like just mainly helps them with motion or helps them with pain as well because you're getting, you're removing the actual impingement points?
Yeah, I think it's both. I mean, the goal is really motion. And, the hope, or at least what I share, and listeners may correct me and tell me they think about it differently, is that we can improve their motion by 50%. In the OR, hopefully you're improving it by more, but what can you keep? And hopefully it's at least a 50% improvement. And I think most patients are happy with that, and that they'll, get back to that functional arc of motion. So there's different numbers for kids and adults, but at least 100-degree arc from 30 to 130 gives you the ability to do essentially all life's activities.
It's hard to convince somebody that 30 is enough in terms of extension because it's just like things like putting on a coat, et cetera, can be more challenging. Even though you tell them the classic numbers, I'm blanking whether that was a Hotchkiss number, an O'Driscoll number, or Maury maybe. I think it was Maury
Maybe
with
more.
30
Yeah.
degrees. But it's just a difficult conversation to have. So I guess the last question I'll ask you about arthritis is that is there a particular amount of radiocapitellar or ulnotrochlear chondral wear that's visible on an X-ray or an MRI that make you say, let's not even bother scoping it?
No, it's really about, for me at least, that determination is based on patient preference and lack of motion. And so if the patient's 40 to 100, I think I can really help them. Um, and if it's bone on bone arthritis, even if motion's pretty good, then maybe I don't, maybe I back away. But it's really the patients that are minorly affected radiographically, but majorly affected with life's activities.
Okay, so before we pivot over to talking about our technical parts, we should thank our other sponsor, Checkpoint Surgical.
Yeah, our sponsor, Checkpoint Surgical, would like to invite everyone, not just Chris, everyone, to join their lunch symposium, Controversies in Nerve Surgery, at the AAHS ASPN ASRM meeting January 17th at 12 in Chula Vista. Be on the lookout for more details.
Checkpoint would also like to wish all of our listeners a happy holiday season. To learn more about Checkpoint's innovative solutions for peripheral nerve surgery, visit www.checkpointsurgical.com.
So I know you're going to this meeting. How long are you going to be out in Chula Vista? And this is at a
So,
new resort, I think.
yeah, so Chula Vista is actually a new resort. It's basically on the way down to Tijuana, on the way between San Diego and Tijuana, is what I understand. I actually was planning on going, but I am not going anymore. The reason being is that, so it's divide and conquer with the kids' activities. And, so we already knew that my son had a hockey tournament in Madison, Wisconsin. So my wife was going to take him to that. But then now that my daughter's doing competitive, isn't on a figure skating team, they have a competition in a different part of Missouri that same weekend. So, you know what? I thought this is my opportunity. I don't have actually a lot of stuff at the meeting. As much as I love that meeting and want to go, this was probably the one where I was going to stay home, or actually, I'm going to be driving to Madison, I think. So quite different weather than Chula Vista, but I'll miss everybody at the combined meeting, particularly at the ASPN meeting.
Oh my gosh. Well, obviously you're doing the right thing for the fam. Talia's driving to Madison right now to pick up Macy, bring her home. She's going to be abroad next semester. But what an amazing town. I hope the weather is somewhat cooperative. I don't know if you spend any time in Madison, but Madison is an amazing place.
That's what I hear. So we actually interviewed somebody from Wisconsin yesterday. The nicest person I've ever met, to be honest with you. Makes Ryan Calfee look like a jerk. No, just kidding. But he was so nice, and it was just such a pleasant conversation about everything. And we were talking about Madison. So anyway, let's get back into our topic about elbow arthroscopy. So can you tell me a bit about positioning? What's the ideal position for this, and how do you set the room up?
Yeah, and that I think is if there's one key to success to highlight, it is that the patient and room setup needs to be done correctly. Thankfully, I'm at the stage where I do this procedure at usually one of two locations, our outpatient surgery centers for kids or adults. I do have one scheduled at the main hospital, and that always gives me anxiety. Um,
Mm.
so I scope elbows in a lateral decubitus position. Some will do them supine. I see the value there, but I've never done it that way. So we're going to speak only about lateral decube. Patients are on a bean bag, of course, with appropriate padding for their peroneal nerve on the down leg. So pillow below the down leg, pillow between the legs. Um, and we use a bean bag. And then the key is that the arm holder, and arm holders are actually interestingly hard, at least in our environment, the perfect arm holder seems to not exist. So how do you support the arm um, and leave the elbow free and allow it to maximally flex, which helps with exposure. And so that's the tricky part. So tourniquet, arm holder, and it takes a couple minutes, but with a good team, it's not a big deal.
So, for those of you that are not watching on YouTube, so it looked like Chuck was taking almost like a U-shaped type
Yeah.
arm holder and putting it just distal to the axilla. Is that about right?
Yeah, the
And then
high
is your tourniquet sterile or non-sterile?
Yeah, so non-sterile tourniquet is high up on the arm as can be, and ideally a somewhat narrow arm holder, U-shaped typically, although there are some flat ones that are good. And the challenge is, especially with a 10-year-old or 11-year-old or smaller adult, is how do you get both the tourniquet, which you can find a narrow tourniquet, but also the arm holder out of the way of the elbow. And it's not hard, hopefully, as long as you have the right equipment.
Yeah, no, there are a number of people out there with a short brachium, which can be challenging, especially in something like this. Or at least you're not making big open incisions. So.
Yeah. And so once you're set up and you prep and you exsanguinate, the next step I would say is the critical one. And what's interesting is I can relate this to wrist arthroscopy. So for elbow arthroscopy, injection of fluid in the joint is critical. And so the idea is through the soft spot, so posterior laterally, you're injecting fluid. Average capacity for the adults, 27 cc's. For a kid, it's lower. But what's interesting is because of that, I was taught with wrist arthroscopy to always inject the wrist, but it's not necessary. And I feel very strongly about that. In the wrist, putting fluid in the joint doesn't help you a bit. It doesn't expand, it doesn't do anything. So I no longer inject in the wrist. In the elbow, putting that fluid in pushes the nerves and arteries away from the joint. So it increases the bone to nerve vascular structure distance, which allows a safer entry into the joint. And I believe that's really important. It just gives you a target, which is larger.
Distends the joint, pushes
Yes.
everything away, right? Okay.
Yeah.
Do you go for the full 27-ish cc's or?
Yeah, you don't want to rupture the capsule, so you don't want to try to fire it as much as you can. But I go till it's nice and tense, and then I pull my needle out and make my portal.
So let's talk about portals. So that I guess posterolateral soft spot being one.
Yeah, that's later.
Okay.
I work anteriorly first for a couple of reasons. One, as you're pumping fluid into the joint, and I do use a pump for most. Sometimes I'll just use gravity for fluid entry. I don't think it's hugely important, but when I'm doing a lot of work, having a pump with constant pressure around the 30 millimeters of mercury, I guess that's right, 30 millimeters of mercury mark, allows a good constant pressure. But so I create an anterior proximal medial portal first, and I do that for a couple of reasons. One, I can feel the medial intermuscular septum. I can feel the ulnar nerve. There's no swelling, and know that my nerve is safe. So theoretically, people talk about a subluxating nerve being a problem. Or a previously transposed nerve being a problem, those are fair. But as far as a subluxating nerve getting in the way, not really a common problem. And you work a little proximally. So I'm usually about 2 centimeters proximal to the medial epicondyle, 1 centimeter anteriorly, and aiming distally towards the radial head. So small skin incision, epidermis and dermis only. I bluntly spread to the capsule, not through the capsule. So create sort of a lane, and then I use my trocar with cannula to punch into the joint. You get your fluid, rush out, which is fine at this point, and you're in.
So at that point, the arm's kind of hanging over the holder anyway. So it's not like it's in maximum flexion, in which a subluxating ulnar nerve would be. After about 90 degrees, that's when you're going to start to see it come up. So if it's hanging in gentle flexion, I would imagine that's why it's not an issue for you, right?
Yeah, exactly right. And actually, when you start your elbows, typically, we position so the elbow's at 90 degrees. What's interesting is when you inject your fluid, the elbow tends to extend a little bit. And so you're probably at 80 or 75 degrees. So you're right. You're safe from the subluxating ulnar nerve.
You can see the things that I care about in this conversation.
I know. We all know what you care about.
But to be honest, I mean that is the one of the main reported complications of all elbow arthroscopy is nerve and vascular injury. So that is top of mind for I think anybody who's doing this.
Yes, and when I was learning to do this, that was the conversation was about the high risk nature of this procedure. I believe there's risk. I wouldn't call it high risk. And so once I have that portal and the camera in the joint, I use what's called a portal dilation system. So a needle is kind of a long needle, which I am able to put in anteriorly, proximally, laterally. So the anterior proximal lateral portal is again about 2 centimeters proximal to the lateral epicondyle, a little anterior, and then you triangulate to put it where you want it. But you can visualize the needle coming through the capsule in a good working position. Now, what's interesting is the easier place to put that portal is more distally, but the more distal or towards the radiocapitellar joint, then your favorite topic comes into play. The radial nerve is much more at risk.
So is this essentially the arthroscopic equivalent of getting into that over the top interval that's used from the lateral side? You're basically going deep, on your mid axial line, right?
Yeah, yeah, that's exactly right. And so once you get your needle in, you incise the skin, use a couple of portal dilation little systems, and then you have a nice portal. And I don't use switching sticks. I don't use cannulae. I don't use any of those. It's just I put my scope in, and then I get to work anteriorly.
And that's your
Um,
working portal.
that's typically the working portal. Occasionally I'll switch them, but usually I view from medially and I work from laterally. And unless there's a strong indication to flip them, then that's what I do. And so again, in these OCDs especially, but in every case, it's just a synovectomy. And again, one other technical discussion point is some will say be careful or don't use suction in elbow
Mhm.
arthroscopy. And I think you can use suction, but you have to do it carefully. The median nerve and brachial artery have been reported to be injured in this procedure, but if you think about it, to get to them, you have to remove the capsule, which in
Mhm.
a non-thickened capsule is not that hard, but then you have to go through the brachialis.
Yeah, and
So,
yeah, exactly.
yeah, it should be pretty safe. So the radial nerve, I guess, theoretically is more at risk, but I don't, I am cognizant of that risk, but I don't feel it's a huge risk.
You're comfortable with the pre-op block for these folks?
Absolutely. I pre-op block. It's interesting because one of my sports partners who I work with regularly doesn't love preoperative blocks for elbow surgeries. Maybe I should, but I don't lose sleep over that. I block everybody. What about you?
I'm a post-op block person. Yeah, again,
Oh,
we're shaped by experiences and a couple of times where ulnar nerve transpositions and there was a questionable neuro exam afterwards. That's all it took for me to be a post-op block person, and I put plenty of local at the end of the day. And I will say that sometimes there is some inconsistency in the quality of blocks, just like there's potential variability in everything we do. But I think that also plays a role in it too.
I
I'd
thought
rather know, and for elbow surgery, I say I'd rather do a post-op block after a neuro check by either me or a fellow resident.
so. Every patient gets a neuro check postoperatively before they get a
If they
postoperative
want to
block.
block, yeah,
Yeah,
exactly. Because
it's
otherwise, I tell them like I have no way of knowing what's going on.
Yeah, we are obviously that's the problem with the way our workflows work. We're all colored by our last negative encounter. And maybe I just haven't had that, but I do preoperative blocks. This is where I'd love a survey of the listeners, and you guys feel free to write in. We are very curious as to what percentage of you would pre-op block versus post-op block in these situations.
Oh, I know I'm in a minority. The pleasant byproduct of that is that it does allowed us to participate in a lot of therapeutic electrical stimulation studies for nerves. Just
True.
because once you do a block, you can't use therapeutic stim. So that's probably why we were the lead enrolling site in one of the studies for eStim. So I guess one other thing I will ask you is, so for your scope, what size scope, what angle scope, a degree, whatever it is, just for listeners who may want to try this in the lab.
Yes, 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 yes. And we should briefly talk about posterior. I know our time is running short. So I will use a standard knee scope. I call it a 4.0 scope for most of these. And I remember in training, Ken Yamaguchi would stress that there can't be any holes. Sometimes the cannulas have little perforations near the tip. So that the fluid can come out in different areas, and he wanted a solid cannula. I think, therefore, that's what we have. But a 4.0 scope for most. I will use a 2.7 in a young adolescent just because it gives me the viewing that I need. Rarely do I use a 1.9 scope. I've done a few scopes in 8-year-olds, and that would be the potential indication. When you go posteriorly, which we can briefly talk about the technical there, sometimes a smaller scope is helpful. So even if I'm using a 4.0 for the anterior part, sometimes I'll use a smaller scope posteriorly.
So talk me through the posterior portal.
Yeah, and this is where there's variability amongst people who do a lot of elbow arthroscopy. I make two soft spot portals just right next to each other. Some people will make one a little more proximal, one a little more distal, but mine is just over the soft spot of the posterior elbow, which is a little hard to see, but I'm trying to point it out on YouTube. And it's a little bit of an awkward thing where you have both the camera and the instrument, typically the shaver, right next to each other, but you get used to it, and then it's a safe portal. There's no real risk. So you basically just incise the skin and bluntly spread and open the capsule, put your scope in, put your device in like a shaver. And then again, you're dealing with posterior synovitis. You can see a plica sometimes, and then you're evaluating your capitellum, and the most common indications, the OCDs and the radial head. And then if your scope is in the more medial of those portals, sometimes you can slip up into the olecranon fossa without even making another skin incision. It depends on the size of the scope, size of the patient, obviously. If that doesn't allow access to the olecranon fossa, then you can make one or two portals. You can make an olecranon tip portal, which is just proximal to the olecranon tip. And then you can make a posterior lateral portal for either working or viewing. And those are easy and safe to perform. Obviously, the whole time you're cognizant of the ulnar nerve. And I probably should have started this conversation by saying, mark the skin. So I draw everything out, including the nerve, the nerve being the ulnar nerve, to make sure we never lose sight of where it is.
There's a lot going on there. So
So they say.
yeah, so I think that, if you are going to try this, certainly, if you have access to a lab, that's probably the best place to start if you're not in training still. Um, are there any other pearls you want to give in terms of your post-op protocols or therapy, or how you think about that before we wrap up?
Yeah, I use less and less therapy with these procedures. If I'm working on elbow extension, so an anterior capsulotomy, arthroscopically, sometimes I will splint the elbow in extension to kind of let things calm down after surgery. For most of what I do, I don't splint anymore, and that includes open procedures. I splint less and less around the elbow unless I feel I have to. Um, the last thing I'll say about elbow arthroscopy is speed matters. There is a clock which needs to sort of be running in your head, and you can also visualize related to elbow swelling. As the elbow swells, it's not that the scope becomes harder, but post-operatively there's more for the patient to deal with and can slow down rehab. But also, if you come out with your scope or your shaver, it can be much more difficult to reestablish the portal, especially anteriorly. So trying just to kind of keep the clock in mind. And that's one reason, and the trainees know this, it's mainly me doing these procedures, which I've tried to be better, making it a collaborative effort, but I'm not perfect.
So your pump's running at 30. How long do you think you have, minute wise?
Um, yeah, I certainly try to be done with the scope by an hour. Certainly done with the anterior work by an hour. And honestly, many times these are much faster. And just I try to be direct and be very focused on what I'm trying to accomplish and not mess around too much.
I was going to ask you if the elbow looks much like, if you do a shoulder scope, the whole thing looks blown up. So I imagine that occurs too if you take too long.
For sure. And it is a technical thing. If your portals are too large, you want a precise portal that's in a good location, not too, you don't want to spread too aggressively because then the fluid extravasates in the soft tissues, just like the wrist. And sometimes in the wrist it happens, and sometimes in the elbow it happens, and you just try to minimize it.
All I can say is that ever since about, probably 10 minutes ago when you mentioned Ken Yamaguchi, all I've been thinking about is you as a resident with Ken Yamaguchi as your attending
Yeah.
and what that must have been like.
Yeah, it was great. It was great. Ken taught me a great deal, and occasionally there were some bumps.
So thank you for that, Chuck, and thank you to Chris Guyton for that topic suggestion, and for giving Chuck the opportunity to talk about elbow scopes after we talked about radial nerve, radial tunnel last time. And we want to wish everybody who listens to us a very happy holiday season, excellent end of the year, and a happy new year.
Absolutely. Thank you, everyone, for listening, for sharing your insights, your requests, and We appreciate the Upper Hand family. Thank you.
Yes, we will be entering year 6 next month. So let's see how that goes.
Good God. All right. Thank you.
Take care.